So what is the U.S. model? And again, this is more for students who are not familiar with the U.S. model. So our model is that you go from secondary school, which is kind of up to certainly through your O levels, maybe even up to your A levels. And then from there you go to university and get a first degree, kind of like getting a biomedical science degree here in this country. Same thing, essentially. But you don't, in the U.S., you don't have to get it in science in order to go to medical school. And in the U.S., you have to get that degree to go to any professional school. So if you want to go to law school, you have to get that degree. If you want to go to business school, you have to get that degree. If you want to go to any kind of master's or PhD school, you have to start with the first bachelor's degree. That's the model. But then you can go to medical school. So you can go to medical school where you can spend another 4 years. And then here's another key difference from Malaysia and from Britain, is you can go directly from medical school to your specialty training without doing any houseman year training. There's no houseman in the United States. You go directly from med school to become a pediatrician, an internist, an OBGYN, a surgeon, a neurologist, whatever you want to be. And that's an important difference. Why can we do that? Because the 4th year of the U.S. medical schools are designed with a series of rotations that essentially give you the experience and the responsibility of, if not more, of houseman training. That's why you don't have to have a houseman year in the United States. And that's why you can go straight into specialty training. Now then, if you want to be a cardiologist or a pulmonologist or a cardiac surgeon, after you finish your core specialty training, you then go on and do your subspecialty training. So for example, I went to university for 4 years and I was actually an economics major. I was not a science major. I went to medical school for 4 years. I then went and did 3 years of internal medicine training. I did another year of chief training. I did 2 more years of research in Europe just because I wanted to do research. I'd never been to Europe. And then I did 4 more years of pulmonary and critical care training. So I'm now board certified. I have a doctoral degree, and I'm board certified in internal medicine, pulmonary medicine, and critical care medicine. I have triple boards, okay? And my pathway was essentially that. What about graduate entry model? One of our professors, Prof. Rampal, is sitting not quite in the back. Yesterday he was sitting in the very back, but he actually moved up 2 rows today. He's actually preparing a report. He's actually writing a paper on the proliferation of graduate entry medical schools throughout the United Kingdom system. And what we're finding is that more schools in the United Kingdom, Asia, and Australia are offering graduate entry rather than undergraduate entry. It's a growing trend. Certainly more schools are going from undergraduate to graduate than vice versa. So I think graduate entry is becoming more of the prevalent trend, and obviously we think it's better, and I'll tell you about the next thing. The findings are that if you allow graduate entry, you get increased student diversity. You're getting older students who have more experience. They may or may not have planned to go to medical school at the age of 17. They may have made the decision at age 20 or 21, like I did. You get more socioeconomic diversity when you have graduate entry. And students, by definition, have more life experience before they start medical school if you do graduate entry. There's a lot of reports and there's a lot of theories that you have increased motivation by graduate entry because students are making the decision to go into medicine at an older age instead of being forced by their parents, frankly. That's the basic point. Students who are older are generally, hopefully, are more responsible, so that by starting medical school when you're older, you kind of have an enhanced sense of responsibility, you're more independent, and by choosing students who choose to go into medicine for hopefully the right reasons, we think that they have a greater sense of altruism also. The curricula, because students are older, can be more student-centric. You can ask the students to do more work on their own because they've already obtained a first degree, they already have a background of experience in the university. The curriculum can be more problem-oriented. You can impose and ask for more research experience because most of the students have had some research experience before they start. So your medical school curriculum, which ours does, has a lot more research. And it allows, by having a graduate entry program, you can start directly into your specialty training. These are all what we think are the advantages of graduate entry. There's been a couple studies that are, again, Prof. Rampal is reviewing for his paper that look at what do the data show. It looks pretty clear, it looks pretty convincing that the attrition rate in graduate entry is lower than with undergraduate entry. The attrition rate at the Johns Hopkins School of Medicine for medical school is less than 2%. Less than 2%. The US average is less than 5%. The best we can tell, some of the averages in some of the schools in this part of the world are on the order of 10 to 20%. So it appears to be a huge difference. The knowledge measures and comparisons, it looks graduate entry is better, but that better be because the students have more schooling, so I hope they have more knowledge. Their communication skills, most people say the older students have better communication skills. Whether or not they have more empathy or not is controversial, because as you get older, sometimes your empathy goes down, but I think that that's controversial. I think that's wrong. And the cost is interesting. There's no doubt that well, not no doubt, there's some doubt, and the norm is that the cost to the individual appears to be greater if you do first degree than graduate entry, because you're talking about 8 years rather than 5 years of schooling, not of training, but of schooling. But it looks like the cost to society might be less if you allow graduate entry than direct entry into specialization. That the society, by having a lower attrition rate and by having less people kind of wallowing around in houseman training, kind of directionless, the cost to society may actually be less if you allow students to go graduate entry right into specialty training. And so it's interesting how you look at cost. Do you look at cost of the society? Do you look at cost of the individual? Obviously, both are relevant. Here's PUGSOM. This is our birth on November 3rd in Putrajaya. There's the Deputy Prime Minister. The Prime Minister was supposed to be there, but he actually developed chickenpox. He got sick. He had to sit this one out. I mean, I've had chickenpox already. I didn't care. I would have been happy to see him. But he supposedly wasn't feeling well. Here's U.S. Secretary of State Hillary Clinton. Here's the Dean of Johns Hopkins School of Medicine, Ed Miller. Here's the spiritual leader of the PUGSOM, the Johns Hopkins PUGSOM relationship, Vice Dean of Hopkins, David Nichols. Here's the kind of the leader of the Malaysian side of the endeavor, Tan Sri Dr. Mohan Swamy, who's kind of the head of the private side of the public-private partnership. This is the Dean of the Hopkins School of Nursing. Here's a very famous American, David Trabulsi, who actually, yeah, we actually wanted him standing there where Hillary Clinton was, but he let her stand in the middle. This is the childhood of PUGSOM. This is our early days, and there's me kind of as the receptionist. Dave Trabulsi was sitting in one of his big offices in the back. In our early days, we actually had, I think, Dave and me and Avi and Prof. Rampal. We had essentially 4 PUGSOM employees for the first couple of days. Those were the good old days. Here's our website. If you haven't seen our website, please go to our website. It's kept up to date. It talks about all the issues and many of the questions you would ask. This is the spiritual leader of Gene Society. So our curriculum is called Gene Society. It is a very novel curriculum that we introduced at Johns Hopkins in 2007? No, 8. 2007 or 8, I forget now. 8, right? No, 2009 we started it officially. We piloted in 2008, we started in 2009. It was first class in 2013. And I was the architect of the Gene Society curriculum. But this is the man who inspired me. This is a 92-year-old geneticist at Johns Hopkins. May he rest in peace, because he passed away 2 years ago. One of the smartest men I've ever met in my life. 93 years old, still worked every day, wore red socks, kind of walked around, and was like one of these just like people who was just smarter. He walked in my, I swear this is true. I was running the old curriculum at Johns Hopkins. I was in charge of the preclinical curriculum at Johns Hopkins. And he walked in my office and said, "Charlie Wiener, I'm Barton Childs." I said, "Dr. Childs, of course I know who you are." And he says, "I just want you to know that your curriculum is totally wrong. You're teaching the students the wrong things." And I said, "What do you mean?" And he wound up sitting in my conference room for 2 weeks, going through our handouts and taking explicit notes and sitting down with me saying, "Here's where your curriculum is wrong." And then he gave me a copy of his book, which was the most dense book I've ever read in my life, and said, "Here's the way we should be teaching medicine, and here's the way the Johns Hopkins curriculum should be designed." It turns out he had a similar meeting with David Nichols, and David Nichols was like blown away and just like trying to process this. And the two of us met, and this was the genesis of Gene Society. And this is a sentence from his book. His book is the most unreadable book in English. In English, for native speakers, it's unreadable. Because he was just so smart, he would write sentences like this. But what he says is that diseases are not caused by what we used to teach. Diseases are caused by the experiences, the combination of your intrinsic makeup and the external environment. And that disease should be thought about as an individual, not as thinking about people as machines. And his contention was that all medical schools taught medicine as people as machines, but people are not machines. People are not cars. People are people. And this is the model that he convinced us we should teach medical school based on. And this is the basics for Gene Society. If you understand this model, you understand Gene Society. So here we have the patient in the middle in blue. and the patient exists anywhere between latent disease or risk of disease, which we all have, on a continuum from there to quite ill, critically ill, almost dead, okay? And we all live somewhere along that continuum as individuals. And where you are on this continuum is a function of your external environment, your society, your community, your family, your environment, and your internal milieu, your genomics, your cell biology, your organ physiology. And it's the interaction between the internal and the external that determine whether or not you're sick, okay? Or even whether or not you got hit by that car or that scooter that you didn't see coming, okay? Because that's certainly your environment and society, okay? So this is the framework for Gene Society. We built an entire medical school curriculum about students understanding the individual from day one. That's what Gene Society is all about. This is actually the curriculum, and for students, the important point of the curriculum is that you start meeting patients from day one, you start learning scientific foundations from day one, you start learning about research from day one, you start learning about ethics and society from day one. You actually, by 4 months into your medical school, you're already being posted to a primary care office 1/2 day a week for an entire year, and that clerk should be run by Dr. Kumar here. Midway through your second year of medical school, you transition to the wards, and by that point here in your second year of medical school, you spend the rest of your time doing heavily intensive clinical rotations. These rotations in the 4th year, starting around here to the 4th year, are equivalent of what in the UK they call housemanship. They're advanced rotations, where you get